In this episode, we'll be chatting with Dr. Claire Phipps, who is a GP and menopause specialist. Dr. Phipps holds a degree in human biology and genetics, sits on the British Menopause Society Advisory Council. She's also trained in CBT and has a trauma awareness approach to her practice and her work. We speak through what exactly perimenopause and menopause is, everything to do with HRT, the myths and misconceptions, and what you might need to know in your 20s, 30s, and 40s when it comes to perimenopause and menopause. Hi, and welcome to Dr. Claire Phipps. I am really looking forward to getting stuck into the questions. About 10 years ago, menopause felt like it was so taboo. I just feel like we didn't really hear much about it. I think awareness is growing, but we also need the research and the innovation to follow. I think a lot of young women as well are rightfully focused on fertility and pregnancy, but there could be some things that we're thinking about and talking about much earlier. Around 450 million women at any point in time will be going through perimenopause and menopause. So huge numbers. So it's so important that we talk about this and get information from experts like you. So before I get stuck into the questions, I like to ask a question that I think is quite indicative of health, either around cycles or sleep. But today I'm going to ask you about sleep. How did you sleep last night and how do you find sleep generally?
Oh, that's a loaded question. I slept well last night, but that's because I generally tend to put in place a lot of things to help that process. It's by no means perfect. I'd love to sleep better. But as we know, sleep is a really tricky thing to achieve in a good way. So my sleep last night was really good, but I do have to be careful during the day so that I can sleep well.
Yeah, I mean, I love sleep. That could be a whole podcast in itself. So I want to start with just a bit about you.
Yeah, so as you said, I am a GP by trade. That evolved into a women's health GP just because by nature you begin to see a lot of women coming through the doors, and then it became a menopause specialist. Like you said, making menopause matter is so important. Education and empowerment of individuals and anyone born with ovaries is so important because I think we just get to this point, many of us get to this point and don't know what's going on, or may have symptoms for years and not really know what's going on. So really, my work is around that within the NHS and both privately and with kind of community-based work.
And now just to start with the basics, what is menopause? And actually, step back. What are the hormones that play a part in female reproductive health? And then maybe we get on to menopause.
Yeah, in terms of reproductive health, we've got the three main hormones that we think about. Obviously, there's lots of hormones at play that probably, almost certainly, have a role in that kind of that system as well. But we're thinking about estrogen, progesterone and testosterone. And those are our three main hormones. In our normal reproductive cycle, we're really thinking about estrogen and progesterone and then other hormones such as luteinizing hormone, follicular stimulating hormone as well. As we approach perimenopause, things change, don't they? We know that things become a bit more turbulent. But in our normal cycle, we're really thinking about two main hormones and then other kind of what I call affiliated hormones that support that cycle as well.
Then on to what is perimenopause, what is menopause, how are they different?
The medical definition of menopause is it's one day in time. It's when you can look back and say, I've not had a period for 12 consecutive months. That is one day in time where you're menopausal. After that day, you're postmenopausal. So in the run up to that last period, you're perimenopausal. And that will be different for every woman. That length of time, how long they're perimenopausal for will be different. And also importantly, it will be different in different ethnically diverse communities as well. So for example, I'm South Asian. In the Southeast Asian population, we know that women can actually have a menopause 5 to 6 years earlier than their white counterparts. And that average age in the UK is around 51. So we're thinking about symptoms probably from our late 30s and up, really. But that perimenopause, don't like to say this too often, but how long is a piece of string? Anywhere between a few years to 10 years sometimes.
So I was going to ask this question actually at the end, but I want to start with something positive before we get into the symptoms and everything. It feels like menopause is kind of terrifying sometimes. What is the good news? Do we have anything to look forward to? In your bio, you talk about how it's an opportunity to take control of your health, which I loved. So could you talk a little bit more about that?
Yeah, and I think the rhetoric around menopause, certainly for younger individuals, has become quite terrifying. And I think we need to change the narrative a little bit about that. It doesn't need to be that way. Look, we know it can be really difficult for lots and lots of people. But actually what we need to be doing is thinking of it in a positive way, preparing ourselves for it in a similar way that we prepare perhaps for pregnancy, not getting pregnant, contraception, first periods, sex education in general. I think we just need to think of it in a different sort of way. Whilst you may have symptoms, some don't, and some don't have significant or severe symptoms. But it's also a second spring. I like to think of it as that second spring, another stage of our life where we're perhaps, a bit older, a bit wiser, a bit more empowered, a bit more educated, a bit more willing to say no, a bit more willing to be boundaried. All of this comes as part of this second phase of our post-reproductive life. And I feel like it's a good stage. Yes, there are negatives. There's a grief process for many individuals going through this. Maybe you've not had children when you wanted to, but maybe also that's an empowerment for some women. They're not wanting to get pregnant, or the sort of, I'm not at risk of getting pregnant, which we'll probably talk about later. That sort of empowerment, that phase of my life is over and I'm on to the next phase as well. Again, that will be different for every individual, clearly, but I think we could sort of twist that negative message and make it a little bit more positive.
I love that. I think I read somewhere someone talking about how that second phase in a woman's life where they really become the teachers of society, which I really loved.
Yeah.
So now going on to perimenopause, what are the symptoms? I think you just said perimenopause can last for any number of years. How do you diagnose perimenopause and how can someone prepare for a consultation with someone like you?
So I think the important thing is that many of us get to our mid-40s and we're just beginning to really understand our own cycle. It takes a while. Things change. We may have had children in the meantime. Our cycles change and we get to a point where we go, I get this symptom before my period, or I feel really hungry, or this is what my psychological symptoms are. And then things start to change again. And it can leave us feeling very confused. So I think the key thing is really track any symptoms you're having, because you'll soon realise a pattern if they're cycle-based. They might not all be, but tracking symptoms really early, and I probably say from our mid-30s up, many of us have got a period at. Can we track what's going on around that cycle, our mood changes, any other symptoms, hot flushes, night sweats, whatever it is for you, can we think about those symptoms in relating to our periods? That's number one. That gives us a wealth of information to perhaps take to our doctors and be able to say, I think this could be hormone related. Maybe this is something we can look into. The important thing about perimenopause is hormone blood tests aren't helpful at that point, because what is happening is the shift in hormones. And these aren't necessarily dropping drastically. These are actually in perimenopause desperately trying to get high. Our estrogen levels are really, really trying to be bumped up at this point. And so if we measure hormones, we often find that they're normal because we've captured them at a normal time. If we measure them 2 or 3 hours later, they might be abnormal. So there's no right time to measure them in the perimenopause. There is, of course, times when we do measure hormones, and that's to rule in or out perimenopause or menopause or other conditions. And certainly in women who are maybe experiencing perimenopausal symptoms earlier than we might expect, it's really important that we do those hormonal blood tests so we're not missing an early menopause or a menopause that's caused by a premature ovarian insufficiency. So different ages, different symptoms will signpost us to blood tests. But really, coming in to see someone, even your GP or even if it's a menopause specialist, it's important to have tracked your symptoms for a little bit of time, 2 or 3 months, just to see if we can notice a pattern.
It's so hard with symptom tracking because I am someone who overanalyzes things, and it could be like a range of things. It could be perimenopause, it could be a lack of vitamins and minerals. What are some of the typical symptoms and maybe not so typical symptoms of perimenopause?
Yeah, and you raise a really good point, because what we don't want to do as menopause specialists is put everything down to menopause. And obviously not everything is going to be perimenopause related. So it's really good and it's really important to have a very holistic overview. When we think of the symptoms of perimenopause, there's loads, aren't there? And actually they could be symptoms of many things. So again, tracking is really important. But your typical symptoms tend to be the ones that are estrogen related, so highs and lows of estrogen tend to be hot flushes and night sweats. But we know around 20% of women might never get a hot flush or night sweat. So we really need to be careful that we're not just relying on that to diagnose perimenopause. We're thinking about symptoms from the age of 40 up, but actually really 45 and up is where we're really looking for symptoms. And it can be top to toe. Joint pains, headaches, change in periods, heavier, lighter, longer, shorter, dry skin, dry eyes, dry hair, itchy skin. Tinnitus is a really interesting one that many people don't realise, that new onset tinnitus can be a sign of perimenopause. Importantly, we don't want to just say it's perimenopause until we've investigated it. Psychological symptoms are some of the ones that are talked about a lot and underdiagnosed. So those tend to be the first signs of perimenopause. New anxiety, new mood changes, and that's often because our estrogen levels go quite high in perimenopause. They don't suddenly drop. And estrogen I like to think of as our party hormone. So it's our get up and go hormone. So it keeps us going. And progesterone, our calming hormone. So as estrogen levels rise, as our ovaries are desperately trying to carry on as normal, our estrogen levels go up, and that can actually make us feel quite anxious, feel quite on edge. And so those are some of the first symptoms that we want to be looking out for, rather than a change in periods or rather some of the other signs. Those are the main ones.
When it comes to perimenopause, early onset perimenopause, this feeling of like, why me? What caused it? Is it something in our genetics, in our environment, our lifestyle? Like, why do we get early onset perimenopause, and where does that come from?
Yeah, so when we're thinking about POI, so premature ovarian insufficiency, which is a menopause or irregular cycles under the age of 40, it's a lot more common than we think, actually. Probably we used to think about 1 in 100. It's probably more like 4 to 5 in 100. Certainly there's going to be a proportion of those individuals that there's a genetic propensity to that. Now, not always. Sometimes there is no reason for this and we can't pick it up on any medical testing. It's just something that happens. But very clearly there is a link between lifestyle, possibly genetics, not that we're gene testing something specific, but genetics, what we're doing, how we're eating, how we're living, what we're exposed to. Are we smoking? Are we drinking? Are we vaping? That's a new one. Are we vaping? So all of these things together probably are influencing our cycles somehow. Do we have the categorical evidence for that? No. But we know that women who probably smoke, who probably drink a little bit too much alcohol, are likely to have a perimenopause or menopause slightly earlier, or experience symptoms, or maybe even experience worsening symptoms. So there's a lot at play, but unfortunately not one firm thing that we can categorically say might have caused it.
Okay. And we'll get on to how people or how women can treat those symptoms in a second. But I did want to touch a little bit more on your background, because you have such an interesting background. You're a specialist in menopause, but you're also CBT trained, and you believe that, and you have seen that adverse life experience can play a part in that menopausal experience. Your trauma-aware approach is so interesting. Can you talk a little bit more about that and how that plays into menopause?
Yeah, so it's a really interesting field because it's really important, as any doctor will know, to be trauma-informed, particularly as a GP, particularly in women's health. If someone's coming into you for a smear test, what is their medical history? What have they been exposed to? Have they been exposed to sexual trauma? How are we going to examine them? How are we going to approach that examination? Are we going to ask for their consent? Are we going to talk them through the process? So being very aware that every person that comes in to see us needs that approach potentially, regardless of if they've had a traumatic experience or not. We know that having a smear is not pleasant. None of us like it. We're exposed, aren't we? And it's not a pleasant experience, but something we have to do. So having a trauma-informed approach is really vital in women's healthcare, because as we go through the perimenopause, what estrogen is really good at, and this is a very simplistic way that I like to look at things, is estrogen is really good at boxing up how we feel. It's very good at protecting our brains, at nourishing our brains, and in a way we kind of box things up and move on. Traumas that we may have felt like we've dealt with, even if that's with CBT or other therapy, we're quite good at boxing it up in our 20s and 30s to a certain degree, granted. As we go through the perimenopause, as estrogen levels start to change, our brains become less good at doing that. So previous traumas can come to a head. The ones that we might have thought that we've dealt with can resurface. Add that to the mix of perimenopause symptoms and it can be a really turbulent time. So ensuring that we are aware of that is important as a menopause specialist. It's important as any healthcare professional, but particularly when we're dealing with hormones, it's really important. And thinking about how we might help that individual go through the process. And this is where that holistic input is so vital, because I think people have become scared of hormones, but scared of not taking hormones. And then in the same way, how is CBT, how is cognitive behavioural therapy going to help me? It's not going to replace my hormones, but we know that a cognitive behavioural therapy approach can be really helpful in changing the way we might think about things, how we might perceive a threat, and how we might manage a symptom in the here and now. So, for example, hot flushes and night sweats. How do we manage that in a meeting environment when we're up doing a presentation or talking to somebody? How can we make our brains relax, rest, talk ourselves down from that? And that, is an evidence-based approach from cognitive behavioural therapy. So the trauma approach is really important, and it encompasses every aspect of a menopause consultation, really. You might not actively be talking about it, but certainly as a menopause specialist, I'm actively thinking about it and listening to what people are saying to me so that I can really pick out what might be more pertinent to that particular individual than, say, somebody else.
It's so interesting. I feel like that could be a whole podcast in itself.
Mm.
Now I want to move on to the myths and misconceptions around perimenopause, menopause. What are some of the biggest myths that you maybe see in your work every day, but also online?
I think the biggest one, and the one that I have to deal with a lot, is you can't get pregnant in the perimenopause. And you can, and we do really need to think about contraceptive options, because you might want to be falling pregnant at the age of 48, 49, but most of us don't want to be doing that.
Yeah.
And I do see women who are accidentally pregnant. And so biggest myth, probably HRT is contraception, and it's not. And that we can't fall pregnant as our cycles change, and we can. And that we probably, symptom-wise, if you don't have hot flushes and night sweats, you're not perimenopausal. And this is something I hear a lot at people being dismissed by other healthcare providers. You can't be perimenopausal because your periods are still reasonably regular and you're not having the vasomotor symptoms that we talk about. And actually, we know that there's hundreds of different types of symptoms that will affect us differently. And I often say, perimenopause is a moving goalpost. You may have one symptom once and never have it again. It may come back, it may be worse, it may be better, it may never come back. So we can't rely on one specific symptom. So hot flushes and night sweats, and also that culturally different perspective in how we experience perimenopause. We know that we need to be thinking about perimenopause earlier in some ethnically diverse groups of individuals. And if you're under 45, you can't be perimenopausal. Again, big myth.
Okay. A myth or something that I've seen that I want to clarify. Can you get menopause or perimenopause if for some medical reason you don't get a period or that you may be infertile?
Yeah, so it's a really good question. So when we think about what perimenopause is, it really is the time when we run out of eggs. Eggs are what is the driver of our cycle, driver of estrogen. So actually, as our eggs reduce, and obviously we're born with all the eggs we're ever going to have, then it's a natural process. It's a natural transition, which is important to mention. I think there are symptoms that can mimic perimenopause. So, for example, if you're undergoing IVF treatment and you're, down-regulating a cycle or up-regulating a cycle, and we're messing around with the hormones a bit, you can get estrogen-related symptoms. I think if you haven't had a period for a while, you may also notice that. So we do notice that in individuals who've had eating disorders, who've got a low BMI, for example, who aren't having regular cycles. We see them experiencing perimenopause-like symptoms because their estrogen levels are low. Is that perimenopause or menopause? Probably not, but it's related to the hormones.
Okay. How does chemical menopause compare to the normal menopause? And why would a chemical menopause have to happen?
Yeah, and this is a really good question because obviously no two individuals are the same, regardless of if it's a chemical, surgical or natural menopause. We all experience it differently. Chemical and surgical menopause tend to be slightly different. Chemical menopause really is when we are giving you a medication or a drug to basically stop the ovaries producing estrogen. And we might be doing that because of a cancer treatment. We might be doing that because you've got severe PMDD symptoms and we want to stop the cycles. It tends to be quite abrupt. It tends to be quite harsh, and we tend to need to do something about it quite quickly. So for many individuals who have PMDD, and I speak to many of these individuals, stopping their cycle is a lifeline. because of the severe symptoms that they experience in that luteal phase of their cycle. And they are very happy, in a way, to put up with some menopausal symptoms because they feel actually on balance better. Many don't, because we are giving them the full set of symptoms often. So we often add in hormones after that, but in a very careful, balanced way. Surgical menopause is when we remove the ovaries, and that is often due to something in your medical history that warrants that, so a cancer diagnosis, or when we're trying to prevent a cancer diagnosis in certain individuals, and that often is an abrupt, severe menopause. So we see those individuals experiencing menopausal symptoms quite significantly.
I want to jump to, if I'm a 20-year-old and I'm thinking about fertility, I'm thinking about hormonal contraception, but actually maybe I should be thinking about later in life, and what I'm doing now in my day-to-day is setting me up for that. What should a 20-year-old be thinking of? Should they be thinking of perimenopause or menopause?
So I say don't worry about it. It isn't I think, like we said at the start, the rhetoric has become so scaring, hasn't it, about perimenopause, and we shouldn't worry about it, certainly not in our mid-20s. We carry on as we are, go and have fun, take your contraception if that's something that you are wanting to do. But what I really would say is start thinking about how you're eating, how you're nourishing your body, how you're moving your body, how you're self-caring for your body as early as you can. If we can encompass strength training from an early age, from our mid-20s onwards, it's going to set us up for longevity in life and a good life and a healthy lifestyle and a healthy older age. So thinking about our bones early, we know bone health and bone density starts to reduce from probably our mid-30s onwards. So can we do something about that? Yeah. Nutrition, movement, resistance training. It doesn't need to be I must hit the gym 3 or 4 times a week. It just can be these exercise hacks that can really improve our bone strength. Of course, we want to always be prepared, but don't worry about it. Do the research, speak to your friends, speak to your family. And I think breaking down that taboo, your mum's still around, speak to your mum. What was her menopause like? What was your grandmother's menopause like? Open up the conversation so we can just be a bit more informed about how it was for our other family members, because we do know that we may experience it in a slightly similar way. Not always, granted, but in a slightly similar way. So in our mid-20s, really focus on nutrition, really focus on how we can support our long-term health. And that's particularly over our bones and our hearts.
I'm glad that you talk about that, nourishing your body, because I think in your 20s, especially like online at the moment, everyone's obsessed with being skinny. You know, longevity is such an interesting area. And I think thinking about nourishing your body, especially in your 20s, getting ready for your 30s, 40s, but that's a whole other podcast. Yeah. You touched on it there, hormonal contraception. There are so many myths that surround hormonal contraception. When it comes to things like, can it bring on early perimenopause or menopausal symptoms? What would you say to that question?
Yeah, I say we don't have enough evidence to suggest that's the case at all. What we often find is individuals who've been on some form of hormonal contraception for a very long time start to come off it around the ages of 40 or mid-40s, when we often, as healthcare professionals, need to change the type of contraception you're on. And they then notice that their cycle has changed and think, oh, what's happened? Is it because of the pill? Or would this have happened naturally anyway? And I think it's more likely the latter. Going back to why we're having perimenopause, it's all around how many eggs we have. So we haven't really changed that by taking contraception. Now, of course, there will possibly be data coming out that might counteract that thought. But at the moment, I don't feel that there's enough evidence to say hormonal contraception affects the time of our menopause, really.
That makes total sense. Thank you for clearing that up. Is there any link between perimenopause symptoms and things like PCOS and endometriosis?
Yeah, so again, really good question. I think with perimenopause, if you've already got a pre-existing gynecological health issue, it may make that worse, it may make it better. We often know women who have had a history of endometriosis, when they reach menopause and beyond, their endometriosis actually gets better because the hormones are less. They're less kind of triggering. If you're going through perimenopause, that's the turbulent time. That's when anything goes, I'm afraid. For PCOS, there isn't much evidence to suggest that perimenopause is going to make that any better, any worse. Endometriosis, there's a little bit of evidence to suggest that could get a little bit worse. So it's really important, obviously, to get the diagnosis, but to manage that really well. And if you need hormones, I think another big myth is that as someone with endometriosis, you can't take HRT, and we know that's not the case. We know that you can. It just needs to be managed by a specialist.
I want to talk a little bit more about, you touched on it before, but how your mother can be quite indicative of how you're going to go through menopause. You said not all the time, but maybe. How can someone like me who doesn't know their mum know what they're going to go through, or is it they don't?
I think it's you don't. I think, unfortunately, what we know is that we may well have a very similar menopause to our genetic mothers, but a lot has changed, certainly I'm 47, and a lot has changed since my mum had her menopause in terms of lifestyle, work-related stress, the constant juggling act, everything else that we're managing in our lives, health conditions, environmental exposure to things. So there's a lot more things at play now in terms of when I might experience my menopause to when she did. There are clearly genetic factors and what we call epigenetic factors, so the tiny changes that in our genes that possibly could alter the way we experience menopause. But we always ask the question, how old were your relatives when they experienced this? Because if they experienced it early, then is that a possibility for you? And that's a question that we need to consider. But it's not a done deal. It's not set in stone.
And when you say relatives, is that always on your mother's side or? Yeah. Okay.
Yeah.
Now, you also spoke about the different lifestyle behaviors and habits that can play a part. I do want to touch again on alcohol because I feel like, well, even myself, I feel like how I deal with alcohol is very different than when I was 20. How does that change? How does a woman's tolerance or relationship with alcohol, how should that change, or how have you seen it change in your patients?
I can talk about how I've seen it change in me. I can't drink alcohol anymore because it makes me feel so terrible, and that's my perimenopause. But we also know as we get older, our ability to metabolize alcohol is different. We get drunk a lot more easily. We feel a lot worse the morning after. And it's simply down to the changes that we're experiencing in our metabolic function as women. And estrogen is pivotal. We spoke about this earlier in terms of gut health. Estrogen is pivotal in so many processes in our body. As that level starts to fluctuate and decline, it has a knock-on effect on various different metabolic functions. One of them is how we process alcohol. That enzyme becomes less proficient at processing alcohol. Again, this is not a blanket rule. It's very individual, but you'll hear lots and lots of individuals say and certainly report to me, I just can't tolerate alcohol in the same way as I did. And in many ways, it just makes you feel worse. It makes your perimenopausal symptoms worse. Stopping alcohol for me has made my sleep better. It's made my perimenopausal symptoms better. It's made my anxiety better. It's made me function better. And it's made me function better as a mum, certainly. But it's very individual, isn't it? And I'm really keen not to be prescriptive about any of this. Also when it comes to nutrition. We want to be good 80% of the time, 70% of the time if we can. But we also want to have some fun. Eat that chocolate, drink that glass of wine if that's what you want to do. But just be mindful about it.
Yeah, it is interesting how much your metabolism changes. Before we move on to the next thing, just thinking about metabolism, I know through my research ahead of the podcast that weight gain in menopause is a common symptom and that women should be kinder to themselves and not put so much pressure on it. How do you see that in your day-to-day with your patients?
Yeah, I feel really sad about this one because if it wasn't bad enough that as women are constantly exposed to what we're exposed to, again, whole different podcast, we hit the perimenopause, which makes us feel terrible. Inherently, we gain weight, and it's not inevitable, but many of us, the majority of women will gain weight. And again, we're unkind to ourselves. We're constantly in this battle of I must fast, I must calorie restrict, I must not eat that square of chocolate, or I mustn't drink that. It's sad. And what I don't want to do is belittle that, because for many individuals, it's a significant concern, and weight gain can make them feel worse from a perimenopausal perspective, but also from a psychological perspective too. And so we need to tackle it. And the reason it's happening is because as our estrogen levels fluctuate, what we tend to see is metabolic rates slow down. We tend to store more fat around our middles and around our bums. Adipose tissue, fatty tissue, tends to produce estrogen. It tends to produce not a great form of estrogen, but it's a form of estrogen that our body desperately is trying to make. And so it's inevitable in a way that it's trying to do the best for you. What we want to do is manage our nutrition as best we can. And that goes back to the basics, doesn't it? It really goes back to be kind to yourself. Think about your body and think about how you can nourish it. And if there is an issue with your weight, think about seeing someone that can really help. So think about seeing a nutritionist. Think about seeing your healthcare provider. Think about all those little tweaks that we can do, the movement, the exercise hacks that might make you feel better from a perimenopause perspective, but might also help manage weight. Look, it's a really difficult area. There is no magic bullet here, but having that conversation starter is vital.
I love the way you talk about the body in that it's someone or something trying so hard, because sometimes we're so unkind, like you say, to our bodies, and it is trying its best. It's trying its best. I love the way that you phrase that. Now moving on to the very big topic of HRT. Can you explain what is HRT, how is it administered, and what the different types there are?
Yeah, so hormone replacement therapy is what we call the gold standard treatment for somebody experiencing perimenopausal symptoms. Now, by that I mean it is licensed and it's regulated in the UK for women who are experiencing symptoms that are affecting their quality of life. Now, that will be different for every person. I often get asked, when's the right time to start hormone replacement therapy? And there isn't a right time. It's very individual. How are your perimenopausal symptoms affecting you? So when we think about HRT, what we tend to prescribe first line in the UK is body identical preparations. All that means are that the preparations that are first line tend to resemble very similarly the hormones your ovaries produce. So the estrogen and progesterone are identical to what they would have produced. Now, obviously they can't be exactly identical because they're man-made, but they are as close a match as we can possibly get and chemically very similar. HRT is estrogen and progesterone. So if you've got a uterus, we need to give both hormones. That's because estrogen, the driver of lots of our symptoms, increases the lining of the womb, and the progesterone stops it getting too thick. So there are different ways you might take progesterone, but essentially HRT is estrogen, usually given through the skin, and progesterone taken as a capsule at night. It's hundreds of different preparations, of course, and there's different types of progestins. Depending on your medical history, we might go for one over the other. But generally what we try to do is give estrogen through the skin and progesterone taken as a natural product orally.
I've heard that some women take the Mirena coil as well as HRT. How does that work? Why would that need to happen?
Yes, the Mirena coil I love because it kills two birds with one stone. So we know, as we've spoken about, that you're still fertile in the perimenopause. So what the coil does is it's first of all contraceptive, and second of all, it provides the progesterone component to your HRT. So the coil can sit in place for 5 years and provide the progesterone to the lining of the womb, so protect the lining of the womb, and then you just add in estrogen on top of that. So it can be a really good double option. The other option is it can reduce bleeding for many women, and as they go through the perimenopause, your bleeding can worsen, not in all cases, but it can be heavier. And the Mirena coil can actually reduce that flow slightly, and in some, stop periods altogether. Remember, when we hit this point in life, we're already juggling a lot. We may not have had any medications before, and then we're suddenly, I've got to take this 3 times a week, and I've got to take that 2 weeks out of every 4. And how do I remember all this stuff? So it just reduces difficulty around HRT.
Okay. And then maybe onto a bit of a taboo question, but I think it's important we talk about it. This is what this podcast is about. How can HRT affect sex? And I read somewhere specifically oral sex. Can you explain a little bit more about that?
Yeah, so hormone replacement therapy in the form of what we've just talked about shouldn't affect oral sex or sex at all. What I've seen a lot of recently is how does vaginal estrogen affect oral sex? So vaginal estrogen is a treatment that we use for genitourinary symptoms. So that's dryness, soreness around the vagina, pain during sex, bleeding after sex. It might be recurrent urine infections. It might be that feeling of bladder instability where you need to pee frequently. So when we give vaginal estrogen, it's given into the vagina as a pessary, as a tablet, as a cream. And I think a lot of what I've seen recently is around, can my partner give me oral sex after I've popped in a pessary? The ideal answer is no, but it's not going to affect him. It's not going to cause any problems. What we normally would say is you use these treatments at night. If you're going to have sex, you might not have sex at night. You might have sex in the morning. Have sex in the morning. Have the oral sex in the morning. If you're having to put the pessary in at night, probably it's better to avoid oral sex, but it's not going to be terrible.
Yeah. What if I don't want to take HRT? What can I use? What's my other alternatives?
Yeah, and this is a great question. I'm so glad you talked about it, because social media is really awash with, I must take HRT. HRT is the only option. 20% of women in the UK take HRT. Why isn't it more? It's not more because of a number of reasons, but also because women have choice. Individuals have choice. And not all individuals want to take it or can take it. So there's a group of individuals who can't take it. There are lots of options out there. So there's some options that I think we've become quite fearful of as medics and as patients, and that is over the antidepressant, anti-anxiety medications. Now, they have a place and they can be really effective. So particularly around hot flushes, night sweats, anxiety, mood-related symptoms, they can be really effective if you're not someone that wants to take HRT. When we think about those psychological symptoms, however, the National Institute of Clinical Excellence guidance over menopause is really clear that if our psychological symptoms are thought to be hormone in origin, HRT is better at treating those than those antidepressant, anti-anxiety medications. That's what we're really clear about. That's not to say that they don't have a place. So there's a whole group of those medications that can be really helpful. There's other medications that can help with bladder irritability, bladder symptoms, pain, joint pain, sleep, for example, hot flushes and night sweats. And then there's alternative therapies. The self-care ones, I think we don't really speak about enough. Your acupuncture, your massage therapy, your yoga, your Pilates, your breath work. Really important to consider how we're breathing at this point in time, because actually that can calm the nervous system down hugely. Yoga Nidra, for example, is a really calming form of yoga that can be helpful too. Now, it might be that one doesn't work for you. Don't give up. We need to try a few often before we get the right fit for somebody.
How do you feel about things like supplementation? Obviously, nutrition and diet is important, but if someone needs to take supplementation, or do you believe that they should avoid that and focus on nutrition?
No, I think it's a really good point. I think what we have to remember about supplements, and certainly from a medical perspective, is we're always going on the evidence. And we know the evidence is lacking for lots of things, but we have to go on what evidence we have for the treatments that we provide, because they have to be safe, they have to be effective, and they have to have been trialled. And those are the three main things we're always thinking about. So what do we have on supplements? We don't have that evidence hugely in robust, randomised clinical trials. And we don't have evidence of safety. And what I'm always keen to think about is, just because we don't have the evidence of safety, we then can't flip that on its head and say that they're all safe. However, there is a role for them clearly. First of all, nutrition and diet, like you said, nourish your body. And if we're not managing to do that in a certain way, supplements do have a role. For example, vegans who aren't potentially getting enough oily fish in a week, we're quoting 3 to 4 portions a week, still quite a lot of oily fish a week. Can you take an omega supplement? I think they're great. I think we should probably all be taking a vitamin D supplement, because we know about the bone health, the fabulous bone health benefits, but also immunity for vitamin D is really important, particularly those with chronic health conditions who are also going through the perimenopause. It can be really helpful. And then there's individual supplements I would personally recommend, and it's in my own clinical practice to personally recommend things based on what you're presenting with. And again, not a huge amount of evidence behind this, but some individuals find magnesium quite helpful for sleep. Some don't. So it really then begins to be evidence-based focus on what you're suffering from and how we might be able to think about supplements. But I wouldn't rule them out. I would just remember to get a really good supplement. When you're looking for supplements, look for the first few ingredients being the supplement you're buying rather than bulking agents.
And then final question on this section on treatment, testosterone. So how does testosterone play a part in the menopausal experience? Ahead of the podcast, I got a question around testosterone is typically given to men. Shouldn't there be a female specific one that you take as a drug? Can you talk a bit more about that?
So testosterone is a really important hormone in women's health. And again, I think there's been really mixed messaging out there about it. And I think we've got to be clear about the evidence base for it. So we know that testosterone can be helpful for low desire, low libido, in women who are already on adequate doses of HRT. Adequate doses is very individual. But in women who are on HRT, or individuals, I should say, who are on HRT and who are still affected by a low libido, that's where the evidence lies for testosterone. We don't use it on its own. We would never use it on its own. It's not licensed for that use. And it's actually off license in the UK. By that we mean we use it in a slightly different way for women's health. So when you think about the preparations, you're right, there isn't a licensed preparation of testosterone for women in the UK. We actually import privately Androphen from Australia, which is a cream-based testosterone that is made for women who are experiencing symptoms. And that, unfortunately, in the UK is only available privately, although the agencies that regulate our medicines are trying to push that to be available in the NHS. But there are really good options within the NHS for testosterone. They are, you're right, male preparations, but we would just use them in a slightly different way, and that's okay. Again, I think there's been some fear over this is a male product. Yes, but we would use it in a female dose. So I think we need to be clear that there are some really good products out there. You may need to see a menopause specialist to initiate that because not every GP is confident in prescribing, which is understandable. But it is an available option, and there's a couple of different ones in the UK that we can use.
I want to talk about post-menopause quickly. And this quote from Rebecca Brown, this is a life stage we step up into rather than fade away into. What is life like for your patients post-menopause? What can women expect in that period?
I think it varies, doesn't it, hugely in how your symptoms have been and how you've looked after yourself and nourished yourself. I think it can look really good. It can look really lovely. It can be empowered and educated. We can't forget that there are going to be a proportion of individuals who still experience symptoms if they're not on HRT. And again, we don't know how long those symptoms go on for. For some, it's not very long, and for others, it is a long time. So we need to manage those symptoms, and that obviously is a very personal choice how we manage them. That might be HRT, that might be something else. But I think the life stage can be really brilliant if we are looking after ourselves. We need to be fundamentally eating well as we can and moving as well as we can so that we can maintain that longevity. So when we're thinking about that, we're thinking about bone density and cardiovascular health. Just because you don't take HRT doesn't mean you're going to fall over and break a bone or have a heart attack. Look at all the individuals before us that didn't take HRT and lived until 90s, 100s. It can still be a really positive part of your life. We just need to probably focus a bit more on it now.
Now moving on to innovation within the space, is there any technology or research or other innovation that you're especially excited about?
Yeah, I wish there was more. I think women's health and research into women's health is chronically underfunded. So I think it's moving in the right direction, and there's lots of individuals doing huge studies around women's health and particularly perimenopause and postmenopause in general. I think there's lots of apps coming out. There's lots of tracking devices for symptoms. Some of the newer HRT medications are coming out. As of the 1st of November, we've got some great new patches for HRT. It's the first time really a new medication has been available for HRT for a long time. And then we've got the studies around non-hormonal based medication for women who've had a history of breast cancer who can't necessarily take HRT. And that's amazing because that's a leap in terms of what we've been able to offer these individuals from sort of non-hormonal based perspectives. So those are the main things. I think the funding is coming. It is slow to trickle through, but it's happening. So that's a positive in my experience.
There are a few things coming down the line in terms of menopause. There is a term that I've come across called menowashing, and it's these new products that are hitting the market, maybe over-promising things without evidence. What do you make of that term or that space?
Yeah, it's a really difficult one, isn't it? You don't have to go far in industry and in shops and on the high street to find a menopause brand. And it's sad because it is a multi-million-pound industry globally. And I see numbers of individuals come in with bags of what they're using, and they'll tip the bag onto the table, and it will be supplements, it will be collagen, it'll be creatine, it will be all these things that you just think, how much have you spent here? I think I'm saddened by it. I think menowashing is a real worry in the climate today. I don't think we should have menopause pants and menopause pajamas. I think we should be just providing women with really good evidence-based information so they can make their own choice. If you want to go out and buy that, please go out and buy it. But what is the evidence behind it? Are you just being bombarded with this message and feeling unempowered by your knowledge? And perhaps that's where we need to start rather than this branding of menopause products.
And I guess with great innovation comes some questionable spaces. And people just have to do their own research, make their own mind up for sure. Now, going on to our last couple of questions here. So how do you think partners of women going through perimenopause and menopause or postmenopause can best support their female partners going through this?
Fantastic question. So in my house, I have 2 boys. I have 3 boys, if you can count my husband. And they all know about menopause. In fact, they're probably a little bit bored of learning about menopause. And my 11-year-old will know all about vaginal health. And I think it's so important that we teach our boys, we teach our partners, we teach our work colleagues as well, because partners can often be the first people to spot the symptoms. And we're not great as individuals at spotting our own symptoms. We just get on with it and we just deal with it. Your partners may be the first people to spot the symptoms. Empowering everybody. I almost think it needs to be a public health message, really. So if you're feeling the symptoms, can you take your partner with you to your appointment? Can you ask them to provide that collateral history, whereas you might not remember everything because you're struggling? Can your partner perhaps come and also come and help you remember what has been discussed? But I think it's a wider message really within communities. It's let's talk about this more. Let's break down the taboos. Let's have this message that menopause doesn't have to be terrible, but let's be aware of what the symptoms might be so we can help fix ourselves and also access the care that we need. Again, another topic entirely, but access to care is also problematic.
Thinking about a lot of these amazing women that are amazing leaders and then they go through menopause, how do you think businesses, or have you seen any businesses or organisations really support the women going through that phase, and what could they do better?
Yeah, it's a really big push at the moment in industry and the corporate world to make sure that we are supporting women in the workforce, particularly when we think about the gender pay gap, the gender pension gap, keeping women in work. Women generally at this point in life tend to suffer more in terms of their pension payments, staying in work. Financially, many women are worse off than their male counterparts at this age because of various different things. Menopause being one, having taken time out for children, for example, being another. So thinking about a menopause policy at work and what that looks like for your employees, but not just having a policy, implementing that policy. How does that policy actually physically work on the ground? Who is your menopause champion in the workplace? Who can these individuals go to say, I'm struggling? Do you have a workplace adaptation that would allow that? And it's so important, as you said, because we know that around 1 in 10 women will leave the workplace due to menopause. We know around 1 in 4 women are considering leaving. Reduces that massive brain power knowledge in our workplace significantly at a time when we really need more women in industry and more women, particularly in STEM. So it's vital that support is out there. It is getting better, absolutely. I was at an event yesterday where we were talking about how we can support women in the workplace and how we can make adaptations in the workplace. And that might be you have work from home a bit if you've had a terrible night's sleep, or you come in a bit later, or adjusted hours, or ventilation in the office. There's a whole host of things that could look like. But I think it is on the agenda and radar a bit more than it was even a few years ago.
And I hope to see more organisations measuring their initiatives, because it's one thing to be like, oh, we've got this mentorship program, or we've got this policy, but are you measuring it? Is it making an impact? So what piece of advice would you say to someone who's listening to this, struggling a little bit through perimenopause, menopause?
I would say you're not alone. Don't think of this as the end of the road, because a lot of women get to this point if they're really struggling and feel like they don't know where to turn. So think about tracking your symptoms. Think about sitting down, and I know this is difficult, for a couple of months and really thinking about it just as pen and paper. What am I suffering from now? What's going on? Take that list to your GP, speak to your GP, find out who in that practice sees the most or signs the most HRT prescriptions. They're the person you need to go to. The people that you need to ask that is your receptionists. They're the gatekeepers. They will know everything. And so they will be able to signpost you. Take someone with you to that appointment. Think about what you want to discuss. Think about, is that HRT or is that something else? And ask those questions and do your research before you get to that appointment. And remember, when you get to your GP appointment, you've probably got 9 or 10 minutes with your GP. So you might need multiple appointments. Don't be dismayed by that. Just book that on your way out. We might need to see you a few times to work out what's going on for you, to work out what's right for you. But have the conversation, essentially, and don't feel alone. Start the conversation. There's some great websites, some great things that we can signpost to.
Where, other than you and the work that you do, where can women go to for great resources, reliable resources?
Yeah, so the Menopause Matters by Diane Danzebrink is definitely one I would absolutely signpost to. She's got a wonderful book as well. And I think what we need is evidence-based information. And there's a lot of noise out there, isn't there? So I think we need to be able to have, what's my go-to trusted information? And then the Women's Health Concern website, which is the patient branch of the British Menopause Society. Also have a look at the BMS website because there's some really great information there. And there's some signposting on there about finding a menopause specialist, for example, in your local area, should you need one.
That's great. Thank you so much. I could have 10 more questions with you today, but we've got to finish. So thank you so much for joining today.
Thank you for having me.
Thank you so much for listening and watching to the Living Health Podcast. If you are suffering with the same condition or you know someone who is, I hope you have practical information that you can take away or relate to some of the things that we've spoken about on this episode. We are always after feedback or recommendations, so please leave your thoughts or let us know who you'd like us to interview next.